in this more sort of psychological end of testing, the clinical end, what you're measuring is not exactly to get to a diagnosis. It's trying to measure the person's capacities in a way that can tell us something about them that they are not able to tell us themselves, and that therapy is not quite figuring out at the moment. And you keep running into a wall.
Okay, Dr. Graham Husick, thank you so much for being here. Season 2, Electric Boogaloo. We are now on episode 3. I'm very excited to have you. Thank you for being here, quite obviously, because this is the first episode in the annals of What the Fuck is Life. This is a long history with pedigree and significance, thousands of years of work. You're the first psychological tester. I don't even know what to call it. I am the layperson, but we're here to talk about what the fuck is psychological testing? Actually, how does it help people? What are the dangers of it, or harm people, and the misunderstanding and appeal to authority, as we talked about, as well as, of course, the differences between academic, neuropsych, psych, clinical psych. I feel like I've gone through a fair amount of education at this point in my career, and yet I don't really know the difference outside of the anxious parent, myself included in that category, of wanting to help myself or my children or what have you. So if you could introduce yourself, thank you again. I'm excited to just listen as you kind of elaborate and maybe elucidate all this darkness and uncertainty and how testing works, how it helps people, and what's going on right now with all these diagnoses that everybody wants or everybody's afraid of.
Right. Well, no, I mean, first, I'm super happy to be here. I've loved your episodes.
Nope. I'm happier to be here.
Okay, well, we can get in a measuring contest about how happy we are, but I guess we're both happy.
Yes.
So, yeah, I mean, hopefully what we can do is both shed some light on this and then also tolerate the ambiguity that still remains even after testing. And that's honestly one of the functions of testing for
Which
patients.
Is so there's a real irony, a real meta irony.
Exactly.
So please, if you could maybe just introduce your background and what you do in a day-to-day sense. And then, of course, we'll jump into what all these tests or testing is.
Yeah. So I'm, like you said, Dr. Graham Husick. I run a private practice out here in Coeur d'Alene, Idaho, called Husick Psychology. And I'm also the director of clinical assessment over at the Lakeside Independence Program, which is...
and that's in the United States, you said?
Yes, not France.
Okay.
As so many people misinterpret. Yeah, right. Yeah, we're in the... If anyone wants to look it up on a map, we're the tiny little sliver between Montana and Washington. It's like we don't even exist.
There's a lot of significance. I wish I was your analyst. Do you get frustrated? Do a lot of people pass through your town on the way to the West Coast?
Absolutely. And I'm happy about SciPac licensure and everything because, I get to see everybody from Seattle and Montana and even travel.
That's good. Yeah.
Sometimes. So it's a great place to be. And nobody from Coeur d'Alene wants me to say this, but it's amazing. Come move here.
Okay. We'll put like a little tag. Do you have is there a website for the town? And we'll add it to the description of the YouTube video.
Probably. I'm guessing it hasn't been updated since the 80s, but we'll see.
Yeah. No, it'll be adorable.
Yeah. So testing, right? So generally the best way I find to break this down is that there's a million different types of testing. And I'm going to be really talking about one particular type today. So there's one side that we probably won't talk about much at all is academic testing. So seeing if somebody has dyslexia or dysgraphia, all the specific learning kind of stuff.
But wait, I don't compelled to interrupt, apologize for interrupting at the same time. I do, for me as the layperson, also for the listener, if we could at least include that in the category, because I didn't even know that academic was specifically dysgraphia, dyslexia. Could you give one more example, maybe?
Sure. I mean, there's all kinds of, my goodness. Yeah. I mean, it can overlap with the neuropsych testing. And that's again, I think what we're going to find is that the boundaries between these are fuzzy, but they do generally separate out into workable categories.
Academic tends to focus obviously on academics, but school performance, test taking, memorization, knowledge, reading comprehension, that kind of thing. But that seems so related, and I'll let
Hmm.
you, I apologize, but it seems so related, like you said, to cognition, to
Hmm.
other forms of cogitation, to other forms of mentalization.
Yeah.
I imagine just even to say that someone who's significantly dyslexic, that would inform the way they think and feel.
Yeah. Right. And it was, I went through as a kid academic testing, and it was
Mm.
enormously helpful to me. I was diagnosed with the dysgraphia kind of issues with fine motors and motor stuff in my hands. And it took my academics from here to here simply because I wasn't able
Wow.
to express what was going on in my mind if I was just to write it. Right. My hand would cramp after 3 sentences, and then that would be that. I mean, academic testing is enormously useful for kids who do have those types of
Gotcha.
issues. But you're right that when we're doing it, we often forget about the person with the problem, and we're so focused on the problem and the person in that way. And so, rarely, I'll do academic testing with kids, but it's rare that I'm just saying, all right, let's do a simple IQ and achievement, and there we go, and we can see the difference between the two, and therefore this kid has whatever they might have. There's so much about the kid themselves, the way that their mind works, their psychology, the family and the family pressures and systems that are going on there that so often if we zero in on the problem too quickly, we start to get that blind men and the elephant problem. We're just paying attention to the tail that feels like a snake as opposed to the whole picture. So that's kind of that academic testing over here. And then there's the neuropsych that again is very useful. If I ever suspect that somebody's got dementia going or anything like that, I'll be the first person to say, okay, that's outside of my realm. Let's send them to the neuropsych. But it also has kind of morphed and evolved to take on any disorder that seems to be relegated to the brain rather than the mind. So autism, ADHD, like we were talking about, the AU ADHD combination piece more often, in my opinion, maybe our first spicy take of the day, but more often has to do with personality than anything really that's going on in the inner workings. Of course, everybody has some idiosyncrasies when it comes to how they think, how their mind works. But yeah, the neuropsych testing, like you were saying before we started recording, like it's taken on so much of a authoritative role. We can tell you about your brain, and therefore we can tell you what disorder you have. And there's like that Rumpelstiltskin effect where people love, there's some level of validation to getting a name for what's going
Right.
on. And so that can be enormously validating and feel good. And I guess put some level of control back in the person to say, okay, I have a name for it, therefore I can start doing something about it. But at the same time, as the diagnoses of autism and ADHD have really risen, so have the tendency to really identify with those diagnoses. And having received those diagnoses from the tester, the source of authority, be able to kind of announce to the world, hey, I didn't self-diagnose. I had somebody in authority tell me what I have, and now I can run with it. And if that works for people, if that fits in with their psychology and it leads to better outcomes, we can talk about the utility of that. But again, the type of testing we really want to get to and talk about, it's still missing the person. And it's sort of barely scratching the surface on who this person actually is and what might be getting in the way of therapy, of them living their life, et
Right.
cetera.
So one of the before we jump into
Yeah.
the next type of testing, one of the major motivators of us doing this episode and speaking in meeting, so to speak, prior, is our shared concern or shared curiosity or
Mm-hmm.
shared consensus that, as you said, the focus on symptomatology and etiology has
Mm-hmm.
come at a great cost to the individual. Idiosyncrasies, idiopathic, generative components of what it means to be a
Mm-hmm.
self, as much as what we would just say is day to day living or suffering, which is to be a
Mm-hmm.
human. And so I'm genuinely, again, thrilled to have you on and discuss with an appeal to your authority. I can sort of feel it in my own clinical gut and say, I'm excited to pick your brain and hear, because I'm not quite sure if the jury's still out. I feel in my education and experience and training and treatment and so on, that the dual aspect monist came back. The jury's not out, the jury's here.
Mm-hmm.
And the brain and the mind are supervened on one another, as the philosophers say, that it's a basic input output system with causal values, propositions, priors, all these fancy theories and predictive processing in a bottom up and top down fashion, right? It's a two-way street. And I don't quite understand, maybe this is my spicy take, how you decipher or delineate the brain from the mind in a meaningful way. That's the key to confer some form of experiential knowledge or epistemic knowledge, intellectual knowledge that really benefits the individual in need. And I guess to say that in more succinctly in plainer English, and what I'm so excited to speak to is, how does testing help? Does it do for us? And how do we negotiate, as you're already hinting at, this reality that the hyper identification, the hyper moralization, and then sort of the hyper disavowal of selfhood in service of whatever my pathology or diagnosis is, or psychopathology, concerning curiosity. And to put a button on it, in my experience, it's mostly, again, anecdotal. How long have I been practicing? But it's mostly I got the diagnosis, which is through knowledge, right? Quite literally. And that provides me this prognosis, future knowledge, that now I know what the fuck is wrong with me. And therefore, it's either not my fault, or it's my parents' fault, or it's the government's fault, or it's Trump's fault. And I take this medication now that it's justified or not, or I do this therapy and this behavioral interventive, manualized maybe, didactic maybe, cognitive maybe, and now I'm absolved, right, of my sin, so to speak. I'm relieved and released from this ambiguity of hell that I don't know what's wrong with me. And so I guess all this is to say, to bring it back to the next type of testing, is this is a very challenging time, I imagine, because of what's so fashionable and people feeling so lost in today's world, that it's, on one hand, you're providing such a wonderful service in a substantive kind of ground truth knowledge. And then on the other hand, it can be bastardized, pivoted, hijacked, polluted by the nature of somebody's, perceptive biases, psychological needs, unresolved neuroses, and so.
Right. I mean, that's at the heart of it. That's the kind of the question I want to answer today is, why is it worth the time and the money? Because
are we answering it today?
I sure like to. I mean, we'll get a start. How about that?
Okay. All right. I usually say to guests, I don't have any answers. The more I learn and do these interviews, which are, again, very meaningful to me, and thank you again, the more I put my hands in the air and say, I don't fucking know, man. Hope maybe you do. I don't know. It seems very complicated.
It's extremely complicated. And with what you're saying, like how the brain and the mind, yeah, I mean, it's so often, I think that there's a socialization process even going into testing, saying,
I'm not playing, I'm genuinely being dumb. I mean, what does that mean? Socialization process going into testing.
Yeah, right. So that so often people are used to saying basically like, okay, there's a test. Like, is it a blood test? And it's like, well, no, except for melancholia, there is one, but besides that, no, we're not.
Is that still? I have to play. I apologize. I have to play with you. Is that still diagnosed? Because that's something I learned in analytic training. But is that still a thing?
I believe so. I mean, I've never diagnosed it myself in outpatient, because typically those patients show up to hospitals in a state of basically stupor,
like catatonia really and stuff.
Extremely severe, right? Yeah. And so there actually is that biomarker blood test you can get for that, but that's kind of
I did not know that. Wow,
isn't it so cool? Yeah, I wish. No, I promise any prospective patients, there's no needles here. Right, so you have to kind of begin the process with people and say, well, yes, we can take a look at the way that your brain works, but it's going to be actually a lot more useful most of the time to look at the way that your mind works, to look and see about your psychological capacities. Sometimes I make the metaphor of like a video game, sports video game, and you've got a player who's got a million different underlying stats, and that makes up the whole player themselves. And if you're just watching the player on the screen, and he's amazing. Let's take football. He's amazing at route running. He's amazing at juking, all this kind of stuff, but he can't catch the ball worth a damn. You're not going to really understand why unless you take a look at the flip side of his player card and realize that his hands are terrible. And so that can be what happens when somebody's in therapy for a while. these are the people that usually come to me, and they've been through several therapies, they've been through several medication trials, and for whatever reason, it's not working. Things aren't getting better. And whether it's the therapist who's referred to me or the person themselves, they're saying like, what's getting in the way? And that's where psych testing can come in, particularly the clinical psych testing that was originally kind of pioneered at the Menninger Clinic in Topeka,
Right.
Kansas, before they moved to Houston. That's where that can come in and tell us something that a normal clinical interview can't.
Could you sort of demarcate that and elaborate again for us lay people? What is being exercised or provided in the testing that isn't in the normal, so to speak, biopsychosocial? What do you mean?
Right. So it's second spicy take. If you're just looking for a DSM diagnosis, 90 to 95% of the time, a good clinical interview or a series of them is going to get you there. That's not really the best use of testing, time and money, that kind of thing. Sometimes there is a more granular, nuanced question that if it really does matter the difference between the two things in the DSM, then some level of testing can be useful. But where that Menninger style testing that I do really helps is, again, like what is getting in the way of benefiting from things that people typically benefit from. Let's take therapy. I have a case example if that might be helpful.
Yeah, please.
So let's say someone comes in, they've been through a few therapies. They finally stuck with a therapist now for over a year, and the therapist talks to me. We're in the same clinic or something, and they say, "Well, look, I've got this patient, and they're really involved, and they are good at attending all of their appointments, and they seem to be sharing things that are quite personal and deep, and we're working well in that, and yet nothing is changing outside. Nothing's really getting better, and I can't for the life of me figure out why. I've tried pointing it out after all these pieces, and I have no idea why. Can you do some testing with this patient? Can you see what might be getting in the way?" And
so just to
yeah.
pause there, I'm laughing or smiling. I'm not sure if it's apparent on camera prior to my acknowledgement of it, because in my world, being so biased, obviously, towards analysis or developmental therapy, I'd be like that therapist needs better training or supervision. And that's not a judgment of their capacities or maybe what they're currently equipped with isn't there yet. Maybe their early career, or maybe they're in the throes of their own development. This is not a moral judgment, but in my experience supervising and being a supervisee for so long, and now teaching and this stuff, and if there's stuckness, and this is why another thing I hope we get to today, I'm so curious about. To me, it's about understanding what's going on in the room, in the here and now, as much as past, present, future, as much as the transference, as much as the content, as much as the drives and drive derivative. There's so many spinning plates you're paying attention to. I would never, and this is my bias, I'm not saying it's right, I would never consider testing as a way through that. I'm so keen and espoused and kind of enamored with what Mary Jo Peoples would say, or Glenn Gabbard, or Shedler, or anybody, Freud, for fucking Kernberg would say, any of my heroes, for lack of a better word, but I got to grieve them because they're just human, but they're heroes nonetheless. And that's what I would do, or I'd seek supervision. But so I don't want to move away your clinical case too much, but I want to come back to this and ask, there's almost a part of me that says, is the testing a shortcut? Or is that such an unfair, reductive take? And then also, how does it work with a longer term developmental, God forbid, psychodynamic psychotherapy? But we can table that.
No. Let's do that now. That's super important. And I love the fact that you met, all the rock stars. Love every single one of them.
I forgot Nancy. And I forgot Karen Murata. And I could just keep going. Murata. I could keep going. It's all these books that I pretend to read,
Yep. Well, and that's the thing, like, particularly with Peebles, who I've worked with Shedler. I love Peebles. I'm going to pull her book off the shelf here.
We have props today, ladies and gentlemen.
I mean, that's, she's the one of the two who wrote the book that really got me into doing this and saying that testing is really it. So, if they're willing to use testing, well, isn't that good enough for us?
Right. Yeah.
But
these people they're superheroes, right?
Yeah. Right. So, why are we going to jump to testing there? And that's one of the first things that I ask when I have a therapist refer to me is, why do we need testing to solve this? Like, it's pretty often that I'll have a patient come into my office and they say that their therapist has referred them. And I say, let me talk to your therapist first. And sometimes it's just a consultation that can help kind of open things up like that. So what can testing give us? Is it a shortcut? Sometimes yes, sometimes it is. And the question about that is like, is it worth paying the time and the money to be able to go deeper faster? I know it's a whole world of like, efficiency and optimization and these kinds of things, and that's why I probably would not recommend going for testing before you ever go for your first course of therapy, right? It's the kind of thing meant to get things a little bit more unstuck or to learn more about the patient to be able to use that in the therapy for the service of getting better. So, right, sometimes the therapist just needs consultation and better supervision. They need to grow in their capacities, but sometimes testing can provide that one or two pieces of critical information and I've seen it over and over, blow open a treatment in a way that it may not have or may have taken a very, very long time to get there without.
So shortcut, so before you jump back to the case example, shortcut is not a pejorative. Yeah. You don't take offense to that.
Well, that's the thing. Not if it's in the service of doing the hard work. If it is that just sort of DSM diagnosis based, like something is wrong with me, I'm going to go get a diagnosis. Now I know what's wrong with me. We've crushed any ambiguity and I just need to go to this specific therapy and take this specific medication. And I guess that's put a ribbon on it kind of thing. That's shortcut for me, what feels like shortcut in the pejorative way. The testing end of things can help us in a way, get somewhere a little bit faster and also tell us things that clinical interview that therapy won't. Like there's certain things that you can measure that don't come out with just therapy. Like the particular setup of testing, the particular environment, what's happening while we're doing it. It's not just the tests. A lot of the time, the best data I get is from talking about the data with the patient during the testing, asking them to psychologize themselves in a way, growing some level of, mentalization in a more sort of brief intervention way like that. So yeah, it's not as much pejorative, I don't think, if we use it in the right way.
Right. So go back to the case example, please.
Yeah. And so this is one, it's going to be an interesting example because we can go back and forth on whether or not it's shortcut in the pejorative way. Like sometimes, different case examples, sometimes you get somebody who is speaking very cryptically. Their reasoning is circular at best or sort of disorganized at worst. And we want to ask, is this following like a neurological logic? Like, does it worsen at times of fatigue or certain times of day? Or is it following psychological logic where that's starting to happen when particular themes in the therapy come up? I mean, that's sometimes one of the referral questions that comes is this something that's going on with them in the brain or in the mind? We do want to try and differentiate between neuro and psycho in that way. So that's just a little sort of side example. That kind of thing, that's the kind of thing where we're really not going to be able to tell without testing, I would argue. So,
and again, it's so alien to me that you could tease apart, in such a way. It seems totally plausible. It doesn't feel totally impossible or erroneous or what have you. But again, in my biases, it seems so unfamiliar to say that you can decisively, critically, unambiguously, unilaterally show that this is organic brain disease or this is not. And like you said, case of dementia, it's so clear. Cases of certain, I don't know what, the fringe cases are always easier to see, the extremes. Someone prolific, unrelenting capital T trauma, whatever you call it, throughout their life. And now there's these quote unquote neurological scarring. I mean, this stuff is clear. But for this in the normal distribution curve, within one or two standard deviations of the majority of the population of whatever demographic, it's much harder and much more ambiguous in my experience. And that interfacing and interplay between brain and mind, between neurophysiology and phenomenology seems almost impossible for me as being someone's analyst to tease apart, because the way they interact and inform and determine one another, I don't know how it would behoove me or them to organize the pathology in such a way.
Hmm.
That's what I'm so curious about, that it would, again, accelerate, like you're saying, the process. I imagine it does happen, like you're saying. It doesn't seem,
Hmm.
it seems very believable. It's more that maybe it's almost to say, like, what would the intervention look like? Or
Hmm.
again, when you're providing, you'll provide more examples of the testing, or like, this is then, an example of where we know that this medication is best. Maybe the example to before I give you back the mic, because it's my show and I love talking. I think of like Nancy speaking to anaclitic versus introjective depression, and this overlap of neuropsychoanalysis, like the Somesian stuff, and what Nancy speaks to in many of her books. But the point being is, we do know that Panksepp's work really,
Yeah.
that the separation anxiety, the panic grief system, responds differently to SSRIs, right?
Hmm.
Than someone with a more introjective, suppressive, depressive, burning, aggressive attack against the self version of depression. In my
Hmm.
experience, of course, most people, again, most of the time, speaking in generalities, have both. We all have
Hmm.
annihilation, destruction anxiety, and we all have separation, anxiety. That certainly involves grief and the denial of grief and change
Hmm.
and mourning. And so, but when it comes to then the pharmacological intervention, boy, oh boy, does that make sense that an SNRI would work differently here, or tricyclic or atypical
Hmm.
versus an SSRI. So to me,
Right.
that's quite tangible. And that was a very meaningful lesson in my training.
Hmm.
But now I'm to bring it back, to bring back to you. I'm so curious what the concreteness is about what you're saying, and that you're teasing these things apart, or able to delineate brain from mind, or however you would say it.
Right. And I think the key to say is there sometimes,
Okay.
maybe in the ways that matter. I'm not going to be able to give an entire, top to bottom profile of every way this person's brain and mind work together and where things are getting in the way. But that, it's the same way that, say, Shedler would say that you have to come and start therapy. You don't start therapy until you have the right questions, the right shared goals, shared
Sure.
understanding of what you're doing together. Same with testing. We could do testing for testing's sake, but that's probably not a good idea or use of time and money in that way.
But is the most, in my understanding, testing for testing's sake at this juncture in almost 2026 seems to be pretty common. It seems to be pretty appealing,
Mm-hmm.
again, in service of, as you said, neutralizing ambiguity,
Mm-hmm.
which is to say anxiety of parents, or anxiety,
Yeah.
concern about their children, in the cases in my mind, as well as adult children too. It doesn't have to be young children, but it's about the appeal of being told.
Mm-hmm.
You go to another type of doctor and they tell you what's wrong. Here's your diagnosis. Here's your medication. Here's your surgery.
Mm-hmm.
Here's where you have to change your food, or what you eat. Here's if you change exercise regimen. Here's
Mm-hmm.
whatever it is. Here's your sleep hygiene. But for us in this world, what's so humbling to me, and fascinating about what you're doing, is that you're working with intangibles inherently, which we
Mm-hmm.
all do in this field. And yet you're working so hard to make them kind of tangible in a kind of, I don't know, like metaphysical way.
Uh-huh.
That's what's so interesting. You got it down on paper, and look at what even my own behavior illustrates my biases and convictions. It's like,
Yeah.
and this is what's going on. And I guess maybe if you could provide more examples, like
Mm-hmm.
you were saying before, to help me understand, because I'm
Right. And I think I
struggling.
have to, my bias, self-confessed obsessional, right? To categorize, to know,
Right.
these kinds
No,
of,
we know you're fucked up. That's why you're on the show.
of course. Yeah. Prerequisite. So, it's, um, right. I mean, we can get seduced by numbers. And I think that's what happens a lot for the sort of run of the mill testing. Is somebody comes in with a problem, we can give the IQ testing, which, to be fair, a lot of those numbers are useful. There's, they're most correlated with some of the, life outcomes and that kind of
Sure.
thing.
And that seems controversial. We would have to do a whole nother episode, but it
Yeah.
does seem in the research that IQ is correlated. It's not causally, we're
Right.
speaking of correlation, with certain outcomes and certain measures in life. So just for the sake of again, and I
Yeah.
apologize for so much interruption, but I'm just so
No, I appreciate
curious that when you're saying outcomes, or the measurements, or the results,
it. Hmm.
that would be an example of where testing can have meaningful information,
Hmm.
information that has causal power, information that has sort of propositional value. It tells us something, and that
Right.
could inform, determine, influence, help,
Hmm.
all these words, in a constructive way, the individual. And even something as controversial as IQ.
Right. Yes, it's controversial. Right.
I mean, I think I don't know enough about IQ, but it's my understanding again that it is reading, casually about it. It's now become controversial. I don't know.
It has. Yeah. And I'm just going to say, for whatever ways it can be misused, there's definitely ways to use it right. And
I imagine
some of the best stuff that we have. So, that is maybe one of the areas where a number can be most useful to us. Someone has an overall IQ of this, but their processing speed, how fast their mind works, which is controversial that they include that in IQ anyway. But, that's down here compared to the rest of their ability.
This is that's so cool. I didn't even know that. So it's measuring the speed also in which you finish the test, or?
Right. Yeah. There's some tests that are timed, and so it can penalize you for not being able to get there quickly enough.
Oh, I see.
And there's also dedicated processing speed tests that have to do, they're all written though. And so that's a confounding measure. Sometimes we have to use other tests to determine, right? If somebody's got dysgraphia and their hand starts cramping after a minute and the test is 2 minutes long, well, we're not getting it accurate. But that's where just knowing the test and knowing the person is better. You can't just administer these and be able to call it good afterwards with the results.
What's a high IQ?
Technically, there's the labels for the different ranges for them, but 100 is average.
Okay, so I just wanted for the audience to know I'm 200. That's why I was asking. Is 200 high?
Well, I think that the record right now is like 212. So
that was me. It was me.
I'm sorry.
So
I'm sorry. Well, no, I think he was Korean. So I think it's,
okay,
you're just not elect. Number 2.
I'm not going to go there in today's day and age. So I got 211 for the record.
Yes. All right. Good.
So joking aside, back to the clinical examples you were providing. I interrupted about IQ.
Well, no, it's okay. Like that numbers piece, it can be useful, but I think like so many other measures, because we have this, weird as in Western educated, industrialized, all that, like because we have that mindset, we can get so seduced by the numbers themselves that we forget where that number came from. Like, what is the source of information we're using from that? So for example, when people are getting tested for ADHD and they're using self-report measures that spit out numbers and they show, okay, this person rated themselves as more likely than 99% of the population to have ADHD. Well, it's kind of circular in a way. It's not actually telling us that much. The person is just kind of putting into what happens to be a number what they've already told us in the clinical interview. It would probably be much more useful to get a measure of what they're able to do live and understand. This is a big point for all of this clinical testing is the conditions under which. Like, what is the conditions under which your attention starts to fail? What are the conditions under which therapy starts to come apart? What are the conditions that often are some of the best questions.
Because I was just going to say, in my amateur understanding, which I'll keep qualifying, the way I've been exposed personally, anecdotally, and clinically with patients is it's casual. The diagnosis, so to speak, is casual, which is not to say it's substantiated by some, metric that's, and it's, in best attempt immunized from bias or what have you, or it's as objective a measure as possible. And I'm blown away that they're using self-report when I just think of all the training, again, in education, we have to focus on in terms of perception, perceptive biases, priors, the coloring and flavoring of the world being how I am, not how it is. And yet you ask a patient or an individual, do you have X, Y, or Z? What does that tell you anything? If I'm asking that in the consulting room, I'm paying attention to as much as what they say and what they don't say. Right? I'm convinced, Dr. Max, I have ADD. Okay. In my head, I'm not taking notes, but in my head, you might as well not have ADD. I don't fucking know. You don't know. You wish to have it as much as you fear to have it. Let's dive deeper into understanding what it's all about, of course, in the context of your personality, your family, intersected conflict, interpersonal, all these things. Again, the spinning plates. But we're asking with this, capital C confounding variable. It's almost like they feel, how many classes did I have to take? Did you have to take in stat and testing? I'm thinking about higher ed. I had to learn how to do that shit so as not to, confounding variables are real. How could
Right.
self-report? I'm blown away. How could that be part of it?
I mean, the thing in testing land is you never make a diagnosis based on the
Is
results.
that where you live, is testing land in Idaho?
That's beautiful. Yeah. And French. Yeah. Like you never make a diagnosis based on one test. And how useful a self-report test like that is, for me, most of the time, little to none. I could take what the patient says in the testing intake and be able to use that and understand their perspective well enough. And that, like this hypothetical patient that you're talking about that comes in and says, I might have ADHD, this kind of stuff. The first instinct I don't think should be to send to testing. Like testing is a specialized tool to be able to answer specialized questions. When you have somebody come in and they're wondering about that kind of thing, I think it is best to go with the sort of well-structured not knowing that you can do together in exploration, which you get is again why, testing for testing's sake is probably not what we want to do. And frankly, in the testings that I do, the actual diagnosis at the end, what DSM thing do they qualify for? It ends up being usually one of the least important aspects of the report and of the feedback. If somebody has one of the pretty I would say valid, this goes back to your podcast with Mark Ruffalo and Nasir Gami's work and this kind of thing. If they have one of these valid, like mood disorder, mood temperament pieces, and that's getting in the way of focus and attention, which by the way, almost nobody's testing for right now. They all assume basically problems in attention equals ADHD.
Right.
That diagnosis can actually be quite useful. And you end up working out a lot of the iatrogenic harm by saying, okay, your attention has gotten better since you've gotten the diagnosis of ADHD and you've gone on stimulants, but the mood stuff has gotten, the anxiety has gotten 3 times worse. We're kind of robbing Peter to pay Paul here. And so, could it be helpful to get this diagnosis of, well, hey, your family history and all this, it kind of points toward mood temperament. What if we got you off of the stimulants and tried you on the lithium, low-dose lithium instead? And that ends up being life-changing for them. Like, if that is the case, fantastic. Testing did its job, although it was, in that case, working out what previous testing had sort of messed up. In this more sort of psychological end of testing, the clinical end, what you're measuring is not exactly to get to a diagnosis. It's trying to measure the person's capacities in a way that can tell us something about them that they are not able to tell us themselves, and that therapy is not quite figuring out at the moment. And you keep running into a wall.
So there's a symmetry with psychodynamic therapy or exploratory, right? Of, like you said, it's tolerating the unknown, being curious and agnostic, and tolerating ambiguity, and ensuring that the questions give rise organically or naturally as much as possible, without confounding your iatrogenic variables, like you said, of what's going on in the person that they don't necessarily have access to. And then the test is built around doing that. And then, which is also fascinating. And then we get into the spicy, to quote you,
Let's do it.
The spicy territory of the etiology, again, neurology, whatever, psychology or psychogenic, neurogenic pathologies of what is ADD or isn't, what is autism or isn't, what is a mood disorder, for lack of a better phrase, or not, what's a personality disorder. And this gets so messy. That episode with Mark, as he brought up, was wonderful in terms of the conversation, exposure to information, and experiencing and feeling through his convictions and beliefs, and of course how he's trained and teaches. At the same time, there are plenty of people who wanted to chop his head off, right? Because he stands quite strong on his platform. My job here is to listen to everybody, so to speak, and be as diplomatic, but also interested, which is at least genuine as far as I understand myself. And so my question is, do these tests then help you negotiate that? Do you have a vertical, for lack of a better metaphor phrase, do you have like a coherent vertical etiology that then illustrates to you, beyond the shadow of a doubt, maybe that's too strong, that this is ADD or ADHD, or this is autism, or this is a depression that's robbing the individual of their executive functioning because of their inability to express all these affects, which comes right back into what I do or the way that I practice in helping the person negotiate that difference.
Yeah.
That's where I don't have any hill to die on. I don't have a flag to plant in the ground, because I genuinely feel so agnostic in saying I could see cases of where it's so, lack of a better word, tangible. It's so ingrained in the sort of neurophysiological fabric of the individual, where it's methamphetamine is the only way to go, or whatever type of amphetamine, maybe not meth. And then in this case, it's like, no, this is an emergent component, is stemming from a prolific burning depression,
Mhm.
repression, suppression, compression of all these affective drives, and of course their ability to then advocate or assert or engage
Mhm.
in life through constructive physiological and phenomenological means, love and aggression, so to speak. It's not possible because the
Mhm.
suppression or repression is so powerful and their personality structure is organized around.
Yes. And so sorry, Matt, my turn to interrupt.
Please, I have not shut the fuck up.
Yeah, well, no, that's the perfect place where testing might be able to help, because it's the point where the defenses are so strong and yet the person wants to figure this out so badly that we can use testing measures that get at what the patient's not able to tell us or not able to express to themselves, to the therapist in some way that can really open things up in a way that brings things into the foray for conscious discussion and exploration where they weren't before. Like that's the perfect kind of patient where I'd want to start seeing them and doing a few different tests, right? It doesn't have to be the massive battery. It doesn't have to be exactly what DSM diagnosis they have like this. I mean, it's a sense of what is going on under the hood. Can we tell a little bit about that enough so that therapy really we can, here's that word shortcut again, maybe, but skip a little bit of the trial and error and be able to get a little bit more of a precise intervention that the testing
So
can also prevent.
could you provide us, me and the 13 listeners, maybe there's 17 today. This is a hot episode. I forgot to put my beard on. Yours looks great, by the way. Give me an example of a test. Yeah. Give me an example of, like, seriously, I don't know these things. What's a test? I don't, Rorschach we spoke about prior to the recording. What else? That's the only one I know the ones from training, back in the day I did clinical social work. So I know MASS and PHQ-9, but what are the ones you're referencing the most or using the most or most
Right. Yeah.
versatile?
So we're gonna set aside the sort of PHQ-9s because that's, again, that self-report, just sort of what
Right.
they manifest or feeling. It's not going to tell us anything more than what they're going to tell the therapist. So we did talk about the Rorschach. I love the Rorschach. It is one of the one of the three core tests in the particular battery that I like to administer and that they did at Menninger. And it's because it can tell us so many different things, but it's maybe some of the most esoteric and numbers focused. And so, I mean, I'd be happy to go into that. It's really good for reality testing and seeing how patients manage emotion and what they, for example, as they're getting towards an emotion that's particularly intolerable for them, how they respond to that, how they come back together, and what's the cost of coming back together, and using those defenses like repression, suppression, all those different pieces. And that can tell us about what's happening in the therapy. So let me give that clinical example because I think that'll spell out some of these pieces for us.
And I'm going to hold you also. I want to hear the other two core that you're saying tests as well.
Yes. Yeah. And so I'll say those now. The other two are some form of sort of broadband IQ tests. So that's the Stanford Bernays or the Wechsler tests, WISC, WAIS, that kind of thing, and the thematic apperception test, the TAT. And so I'm going to describe that one more in particular because it's it's sort of the middle ground in terms of ambiguity for the patient. Because, right, the Wechsler, the intelligence tests, those are so task focused and very clear about what they're asking for that it's the least ambiguous, and therefore, except for performance, anxieties that come with that, some of the least anxiety provoking part of the testing. And then you get to the TAT, which is stories that we want people to project their psychologies onto, involving characters and feelings and all that kind of stuff. And that is the one that I love asking patients to psychologize themselves with me right after the test, because we can look across the 10 stories that they told and find really important themes or ways that characters relate to each other. It's wonderful for kids as well. There's a children's version called the CAT, Children's Apperception Test. And that's with little cartoon drawings and everything. Sure. It's just wonderful because kids are expressing so much that, of course, they're not able to communicate because they're 8, right?
Right. Or 5. Right.
Right. Exactly. All the way down. Yeah. And then of course the Rorschach. So taking the patient example, let's say, this is the therapist that's referred them to me. They're saying so much of the therapy feels as if it's going right, and yet we cannot figure out why, what is going wrong, what is in the way, such that nothing is transferring outside of the therapy, or that it feels like when we get to certain topics, we sort of get stuck. And so I talk with the patients and they say, yes, I love my therapist and I tell them everything and I feel very safe with them. In fact, much safer than I felt with my other, the other therapists that I tried working with.
Yeah, all the therapists are shitty until they come to you, right?
Exactly. Of course. Yeah. So, we get this picture, and so we start to build the questions of what we might want to ask, like what might be getting in the way, given the fact that this patient seems to be relatively intelligent. So it's not an issue that I think we're dealing with. They're articulate. So, the idea of putting feelings into words is not exactly the issue. We start to ask about their history and see, what's there. And so we start the testing to see basically what's getting in the way of therapy, what's getting in the way of transferring it to the outside world. And let's say we start with the intelligence test. And they're doing fine on it. And frankly, intelligence is not the most important thing about this test. It would be nice to see, are there any major discrepancies, any major areas of strength for them that could be used in the therapy? For example, if somebody's much higher in visual spatial abilities than verbal, then using visual metaphors in therapy often tends to be something that can really help their learning style.
This is the kind of shit, this is helping me. Thank you. This is what the example, thank you. Because I didn't even know. I know those phrases, thankfully, right, that you're using, but I didn't even realize what you're saying. That so then the therapist transforms, converts, reforms their language based on the strength of their understanding.
Exactly.
It reminds me of like my in fascinations and interests and passions is aphantasia versus hyperphantasia, and so how that's used in an analytic. In my world of if somebody can't imagine an apple versus somebody who can imagine it with vivid capacities and it's attached to this network of memories and explicit and implicit, blah, blah, blah. It's a very different type of therapy. And so that was thank you. That was very helpful. So now that's like again, it's concrete to me in my conceptualization.
Yeah. Wow. Well, buckle in because we're going to have a lot more.
Oh, wait. Okay. I'm ready.
Yeah.
I wish I don't have a seatbelt on my office chair. I apologize.
All right. Well, here we go. Yeah. I mean, your wonderful hair might get a little messed up.
Thank you.
Right. So, we're doing this intelligence test and the patient is, they're basically acing it as much as you can. They have a pretty high IQ. And I myself am noticing that I'm starting to rush through it as a therapist because there's a limited amount of time that we have. And well, there's other things that we want to know about. And partially into the testing, the patient says, are you in a rush? So now we're outside of the realm of just what the numbers are going to tell us. And I can see that the patient's actually been watching me the entire time. And I have to consider then, right, because in analytic therapy, neutrality, that kind of thing, we want to explore that with them. I have to consider, what do I want to do with that? Do I want to say yes or no, depending on whether I am or I'm not? Do I want to explore that with them? And for some reason, I'm pulled to say, you know what, I am in a rush because I'm more interested in what other testings are going to tell us. And, he says, okay, thank you for telling me. That helps me understand what's going on right now, what I was picking up from you. Okay, that's a whole realm of information that we're not going to get from just the numbers that spit out on the intelligence test.
So to me, again, you're employing just countertransference, right? You're wringing out the information out of the countertransferential response.
Yes.
And still employing the test.
Yeah, they call that patient examiner data. So that,
okay.
Yeah, right. The countertransferential stuff. And what's interesting about that is that, we can say, okay, the patient was very attentive to not just the testing, but the examiner themselves. And what was it about that intervention? How did that help or not help? Right? Because in a normal analytic therapy where you're going to more explore what's behind the questions and actually answer the question right away, this patient might not do so well with that. There's something about me expressing my internal sense of self or sense of what's going on that's very calming for the patient. Okay, that's going to tell us something about what might be happening within the therapy. So that's a source of data outside what any of the tests are going to give you, and that's really dependent on the person who's giving the tests. You can't just be the psychometrist who happens to know how to give an intelligence test and expect to get the same level of data if you're not also trained in how to do therapy. So we do that test, and then we go to the TAT. That's the storytelling task. And I'm not going to show any of the cards here because with copyright and that kind of stuff.
Sure.
But the basic premise, anyone can see this on YouTube, is there are these pictures and we want the patient to take a look at them and tell us stories about them. And they're meant to pull for certain things, right? Certain cards pull for aggression, certain cards pull for affection, conflict and conflict resolution, disappointment. I mean, we're showing the same cards every time because we know generally how people on average respond to them or form stories around them. And it's the deviations from that can be really interesting to us. So, for example, I'm going to read a totally de-identified and sort of, I picked out the most important response to a particular card, and that will tell us something. You have somebody who the card will depict generally what the picture is and what generally looks like an older guy is standing over somebody who's younger and on a bed, lying face up with their eyes closed. And so that can pull for a lot of different things. That particular card is pulling for helping relationships. So this guy's holding his hand over the younger person on the bed. And, sometimes that can be interpreted as something aggressive.
Sure.
He's going to choke the younger person. But most often it's something that somebody is going to interpret. Oh, it's a child and they're sick, and the older person is a priest who's praying over them and going to try and make them better. And then I can ask questions like, will it work? Will that praying work? And that can give us clues about whether this person believes that helping relationships really can be helpful in a way. This particular patient on this particular card basically talked about the person is trying to help. The person on the bed is sick. The person who's trying to help is not going to be successful at helping. And the reason is because they gain quite a bit from being the helper. And so they're actually going to keep the person sick just alive enough so that they can keep trying to help them, quote unquote. But, that they're going to not actually help enough to save them because it's beneficial to them.
Yeah,
so
wow.
This is pretty different from, I love my therapist, I tell them everything, right? I mean, and especially the fact that this showed up across different cards, that every helping relationship was suffused with suspicion, paranoia, aggression, that we start forming a hypothesis that maybe the patient is actually kind of scared of their therapist. And that for some reason, that wasn't showing up enough in the room for the therapist to pay attention to it, or we're bolstering a therapist who might otherwise, with better training or supervision, been able to point that out to them and be able to use that in the therapy. So I can keep going. I can do the Rorschach examples and everything.
I'm silent, gobsmacked. My jaw's on the floor just because it's just to have, well, there's many, many thoughts. One is, of course, it seems similar in my understanding to, in many ways, to the work I do, many ways to the Rorschach test and the limited I understand about it, coloring it, flavoring it, are perceptive. The narratives, we employ, and how they represent our projections, or interjections, but then they're brought out through the card. And so I'm thinking, is that a shortcut? Is that not? It's really interesting. And then I'm thinking that poor schmuck of a therapist. And I'm like, how do you not see that the patient is quite obviously, factitious disorder or Munchausen's or whatever? And it's like, they're obviously have a paranoid personality structure, but it's veiled in this sort of pseudo affection. And then I'm thinking about all the Netflix shows that involve this, and that's where my head is right now. And I guess, I'm fascinated how supplementary this truly can be to the work trademark. I'm asking myself how I would use it. And then I'm coming back to, of course, this relationship we spoke to, of how much is it for the patient? How much is it for the therapist? Back to, like you're saying, supervision, whatever, better treatment, better supervision, better education. And then how does this relate back to the brain mind thing as well? Because I don't know. I've certainly treated patients with forms of Munchausen's or factitious disorder. I treat patients with paranoid, have patients paranoid personality structures. I don't know what I would do with this information if it would change course of the treatment for me. And again, I'm back to that thing of, is this more for the therapist than the patient? I mean, it doesn't have to be. It's mutually inclusive. And then how would it help me understand the etiology again of something being organic versus psychological?
Right. Well, and that's considering in this case whether the etiology matters as much. The idea of neuro versus psychological logic can be helpful when it's happening, conditions under which. But I think that's a fantastic question. The idea of, is this more for the therapist? Sometimes. I mean, the recommendation sections for patients in sort of the run-of-the-mill average everyday testing are all geared towards the patient. And there's typically 5 or 6 generic recommendations based on each DSM diagnosis they get. So there's like 30 or 35 recommendations and the patient just gets lost. It's not very helpful. But if I can write this report and describe how this patient's mind works and how their brain works, or at least how, what logic things are following, and I can write half the recommendations to the therapist in a way to bolster the therapy itself and reveal things, and it's helpful to the patient by being helpful to the therapist. I think that's how the testing originally came about in the Menninger clinic. It was for therapists who were treating these patients who came in that were quite severe, disorganized, dysregulated. They didn't really know what was going on, and so we could tell a little bit more for those kinds of patients. And now this is just the outpatient model where things can be a little bit more subtle, but no less distressing for people.
Before we get, for the sake of time today, we get to the spicier things about fashionable diagnoses and appeal towards authority, all these sort of cognitive or logical fallacies we all employ. What's the difference, just very quickly, or as briefly as you can, with the Rorschach versus TAT?
Right. So the Rorschach is the most ambiguous. So it's the most sort of anxiety provoking, right? Tell me what this ink blot looks like. What do you mean? What are you going to, if we have the paranoid patient, what are you going to derive from this? And so that, they can start being cagey, stuff like that. But let's say you don't have somebody who's got that structure. The Rorschach has been so normed across time that you can really tell the difference between them and the average person in the way that they do so many different things. It's going to be hard to be brief about this because there's so many different pieces of data you can get from it, and which is why it's worth it, because at the end, it takes an hour or more to administer often, and it takes more than that to score, interpret. I mean, it's the biggest, chunkiest, meatiest part of the assessment. And it can tell us things like it's pretty much the best test out there for subtle thought disorder. It's one of the best tests out there for, you can look at emotion regulation across different tests. Like the TAT, you can see how they describe that characters put themselves back together after emotional experiences. Do the characters dust themselves off and move on into the future independently? Do they seek out help from others? Do they kill themselves? A lot of different potentials. Same thing in the Rorschach, but it's a little bit more ambiguous because some cards are more emotionally activating than others. And we can see what happens when they get to that place. Do they get really detail oriented, or do they blow out the whole picture when they weren't before?
How many cards is it?
10.
It's always 10?
Always 10 in the Rorschach.
Okay.
I mean, there were others produced, but for the big systems that have been normed, as opposed to just saying like card 4 is the father card, and so when you see a monster, it can be interesting, but the best source of information really is the numbers and what they mean on that particular Rorschach test. So the TAT, there's dozens of pictures, and you can switch them out. Some people switch them out depending on male versus female, that kind of thing.
And let me ask the stupid question: the Rorschach, those 10 cards, they've been the same for how long?
Oh goodness, when were they? Was this the 30s or the 40s? When
I don't remember from school. I don't remember.
Right, long enough that they're out of copyright. That's what I'll say.
Wow.
Yeah,
and again, pardon me for my naivete. Everybody uses the same 10 across the world, or how, as far as you know?
I believe so. I mean, there's different systems. There's the comprehensive system, which is what I use. It's older and the norms are older, so you have to be careful with that. But it's also what was developed at Menninger, or what they used, and so that's what I use. There's the newer RPAS system that can also be very useful, and some of the stuff that they brought over from RPAS, the Rorschach Oral Dependency Index, and these can tell us certain things. But yeah, I think it's usually the same 10 across time.
Wow. And why are they all pictures of vaginas?
Right, exactly. Well, you'd have to ask Rorschach himself about that. Okay. Or it's my parents.
I have some colleagues in mind that are really going to laugh at that joke. Okay, so to get back to the diagnoses, God, I was preparing that joke in my mind for like 5 minutes. Like I was really excited
you nailed
about
it.
That one. Thank you. I landed the plane. So to bring it back to the spicy part, how has this informed you in your understanding of fashionable diagnoses like we're talking about? Nowadays, everybody, of course, has anxiety. Is it a disorder? What is a diagnosis at this point? Is it normal, quotidian?
Mhm.
Everyone's depressed, right? And then
Mhm.
everyone now is ADD or ADHD, which maybe you could elaborate on the difference with your tests, because I
Mm.
don't think that's agreed upon. And then and now with autism diagnoses. So how have you been employed, so to speak, for lack
Mhm.
of a better word, given the current landscape or zeitgeist or a lot of these quite large enactments in our culture?
Yeah. Oh boy, it's a great
Yeah,
question.
I know it's a big one, and you don't have to
Yeah.
get too controversial, whatever you're comfortable with.
I've people who know me and for my program, I don't shy away from controversy.
Okay.
I'm ready. I'm ready to talk about it. It's just it is controversial because people build their entire careers off of it. And
Sure, sure.
who am I to say this? Besides the fact that I've seen firsthand the helpfulness that sort of true in-depth psychological testing can have, and also the harms that pretty shallow diagnosis-focused testing can also do. When you've got a particular center for testing for a particular diagnosis, we are the ADHD center, we are, something like
Oh, I
that.
see. Right.
I don't have the numbers on this, but it's probably pretty easy to guess that most of the time they find ADHD. And
Right.
there's a self-selecting, bias with that people who might really have it go and get
Sure.
testing there because they're more knowledgeable about it. And they've read on the internet these kinds of pieces. But I've personally gotten many reports from places like that, and they've just missed things. They've missed the mood temperaments, which is like 20% of the population or something like that. I mean, it's no small piece to miss, especially when you're prescribing such powerful things as stimulants. So when somebody comes in and they're really focused on the diagnosis, you're asking how I've been employed in it. I have the conversation with them ahead of time because I don't want to waste their time and their money. That it is possible that you have that diagnosis. We can look into that. We can do the testing and find the best that we can, although I go through, that each of the diagnoses really are just our best way of explaining things.
Right.
We have a lot of chronological kind of snobbery as I think it was C.S. Lewis who coined that. Like, we think we know all the answers now with our names of diagnoses, and therefore, we are so much more advanced than the people from before and all that kind of
Right.
stuff. Some of these are just sort of the best descriptions of symptoms that we have. ODD, classic,
Sure.
get diagnosed with that all the time. And it's like, okay, but so they're oppositional. Why? Is anyone interested
Right.
in?
Exactly.
Yeah. I mean, sometimes they're just interested in labeling the child in order to basically locate the problem within the child.
Right.
And that's a big question for us in the testing is we can only test the person who's there. And so what if the problem isn't actually there? What if it is a family systems issue? What if there's something that's not really, that there's a big family secret that no one's going to let on, right? And, we're testing.
But this is, I know. So this is, you're in what's the word? Igniting me, impassioning me, because that's what in my consultations, my trainings, what I provide, my treatment patients, that's a huge variable. It has causal power, especially the younger the child. The idea that you could treat a 5-year-old or 4-year-old or even sometimes younger without treating the parents and to deny the possibility of interpersonal or interfamilial pathogenesis versus intrapsychic. And the fact that it's mutually inclusive. It's always both and, as Gabbard would say. It frustrates me to no end, as I'm sure you've heard me say before, and it's still happening. So with these diagnoses right now being I can't think of a better word than fashionable. Maybe there is one, or popular. They've become so diluted, they almost seem meaningless. And yet everybody is desiring them. I think a large part of it, of course, speaking in generalities, is the appeal, like you said, that I feel more in control, the locus of control being inside of me, but the locus of the problem, the location of the problem being inside the child, like you said. And now I feel better because now I know what's wrong and it's not me. And it's a huge problem. It's like you said, we're so intolerant of ambiguity, of overdetermination, as Nancy so eloquently speaks to, right? Of the problem of psychopathology. There's so many variables operating at once. So I guess, again, you spoke to ADD and the context of a mood disorder versus what would be the other category, if you will. Would you say it's more organic in that? I don't mean to put you on the spot. I'm curious.
What do you mean?
If it's not an extension of a mood disorder or a symptom of, tertiary, secondary layers, when it's, so to speak, real ADD, there's a difference in the testing?
Oh, goodness. Yeah. I mean, you can see, and again, it's about what this diagnosis used to mean as opposed to what it means now, and how far these expand. Same thing with autism, that it used to be sort of a prescribed syndrome in a way. And then you started add sort of some of the Asperger's on there. And these are all fascinating things, and everybody has a lot of different opinions on them. But it's pretty undeniable that they've expanded and absorbed to take on so much of human psychology that it's basically like, right, it's not saying anything particularly meaningful a lot of the time about the actual person. And so
Right.
like autism, for example, has absorbed so much of the personality discussions that used to happen that, it's not that this person has schizoid with, avoidant schizoid sort of tendencies and what that means for the person. There used to be a pretty prescribed or, circumscribed syndrome that now, it's expanded because, again, ADHD, autism, where is the problem located? We're placing it in the brain. It's not in the mind. It's in the brain. I can't do anything about it other than some therapies, and it's just part of me, and that it just obliterates any ambiguity and understanding of the person behind it.
We're collapsing the possibility, totally collapsing, crumbling an opportunity for discovery or understanding because we're necessarily prescribing a diagnosis. And in doing so, we'll never understand, like you said, the actual etiology, organization, and genesis of this disease or nosology and etiology in a way that's meaningful. And what do we mean by meaningful? Well, causal power has information, tells us something. It has a sort of an efficaciousness, if that's a noun. It helps us understand how the person's functioning in day-to-day life as much as in all these contexts of family systems, societal systems, what have you. And all that's going out the window to say, okay, this is a immutable, genetic, in the brain, no ifs, ands, or buts. And that's all there is to it. So you either do this behavioral modification or intervention or cognitive type of treatment or emotional regulation type of treatment. And then, of course, the psychopharmacology or pharmacology that goes into it.
Right.
And that's, and like you said,
just
it's
like nerves diagnosis that from a while ago, it was so much more comfortable to put the idea of the location of the problem in the nerves in the body or the wandering uterus or any of these. Right. Like, it's about how closely do we want to look at ourselves, and can we use the tools of testing in a way that enhances that or that shuts that space and that capacity down. And the nice thing about you're saying, the parents who say, and this is unconscious, right? They do want the best for their kids a lot of the time, the problem's in the kid. And sometimes testing can be a nice both and, there are burgeoning personality problems within the child. There's no question. And some of that's probably genetic, some of that's probably environmental. Biggest environmental factor is parents. Kid might need this kind of treatment. We describe the personality difficulties in as, specific terms as we can. And would you like to enter psychotherapy in order to help with this, to help your child? And
my gut is about to scream no, because that's my experience in terms of most of the time that parents, that they don't want to work through the shame, the guilt, the anxiety, the paranoia, all of it. And so again, they want the location in the child.
They do.
But you're saying they do say yes?
Oh, I have to tell you, several of the patients that I see right now are parents of kids that they brought in for testing.
Well, that's nice to hear.
Yeah. And it's, as far as I can tell, it's helping. And it's what got them into treatment in the first place. And it expanded, even though it ended up with some kind of a diagnosis for the kid, and they, on some level, think that the problem is in the kid, which sometimes it is. It got them thinking about their kid in a more complex way, because I did the type of testing that is more specific and not just diagnosis oriented. We can start to think about the kid as more than just problem diagnosis. We start mentalizing.
Or a narcissistic extension of my, or object of my own displacement, my own anxiety and efficacy, whatever. But what a cool thing. What a wonderful thing to maybe optimistic, dare I say, in this fucked up, crazy world, that a test and its appeal as some authoritative, objective, scientific, right, scientism-y tool can then be used to seduce a parent in a constructive way, not an unhealthy way, into treatment, and then help them expand their mentalization, their reflective functioning, their conceptualization of a child, holding on to more truths, more than two truths at once, or more than several. That's very interesting. I never thought of it that way either, because then you're almost sort of taking advantage of the neurosis and saying, well, no, but now because you think this is so legitimate, I'm going to really help all of you guys, or the best I can.
Right.
So before we wrap up today, what's going on lately in the context of what we're speaking to now? Is this happening a lot? Do you see an increase of you being employed or deployed as the authority for what people's desire for diagnoses? Or is there a trend that we're not aware of, people in the field, but outside of what you do?
Yeah. I mean, I think there is always the pull from the patient, because we're not the therapist. We as assessors are the people who are supposed to have the answers, who can provide some level. So, oftentimes people really are like, they're not just looking for an identity most of the time. They really are saying like, what is going on? What is wrong with me? And, we try and be as helpful as we can, but I think it's about holding the frame of testing in that way, that if truly the person is really just looking to be diagnosed so they don't have to self-diagnose because they've already decided what they have and that kind of piece. I mean, that's where you have an honest conversation with them and you can say, it's not really the use of testing. I mean, I've had several patients come to me because their spouses referred them for autism testing. You have autistic anger, or because you're introverted, that must mean that you're autistic. And with those patients, it's patently clear when I see them, and then especially from their history, that's not what's going on. And yet there's still something to be explored here. And so I asked them if they want to explore that in psychotherapy with me, and they do, and it ends up helping. The incentive, particularly market incentives of a lot of different testing centers and all that kind of thing, yes, the pull is have the answer, give the diagnosis, give the people what they want. And I'd say, like any powerful tool, you've got to use this responsibly, or you end up doing more harm than good.
And that's, that's quite obvious and clear, and yet it's not. I think in the tri-state area, New York, New Jersey, Connecticut area, and I without naming names, of course, if I'm sued, I don't have a team of lawyers doing this for free, but I know of those places. One in particular is coming to mind in Manhattan, and it's famous for its, let's say, its comprehensiveness, and yet it's infamous for providing what the parent or child or adult child, whatever, wants. And it's extremely expensive, as far as I know, through anecdotal evidence, third-party information. Yeah. But that expense is part of its pedigree, so to speak, or its bouginess, or its accessibility, or inaccessibility for that matter. And so therefore, there's more authority to the diagnosis, which nowadays is usually all this sort of neurodivergent umbrella, which we didn't get to speak to, but kind of did. And it's next time, yes, yeah. AUDHD, or however it's pronounced. And it's disheartening, I guess is the word it's dispiriting, it's disheartening. On the bad days, you feel quite frustrated, maybe to speak in the general you, of these poor people, or these poor children, or what about everything we're speaking to? What about the meaning and function of what's going on? And all of it's just eradicated. It evaporates, and the family, in a sense, feels better, kind of like a drug, ironically or metaphorically or not, at the cost of the humanity, idiosyncrasies, the individuality, the reality, the authenticity of the person in need. And that's it's so frustrating. It's so hard to tolerate. I'm sure you hear it more than I do, but I hear these stories and I'm going, what the fuck? Dr. Schwartz, the neuropsych here, said, and that's in ODD and ADD and neurodivergent, and they have this extra test timing on the test, and they're going to get this help at the recess. Okay, sure.
Where's the person?
Where's the person? Right. Where's the child? Where's the human? Where's the soul? I think of Jim Hollis. You make me think, and I think of the psychotherapy. Is it Greek or Latin? But the healing of the soul, psyche being soul, and therapy being healing. It's like, what are we doing?
Yeah.
So anyway, I thank you for doing testing in service of understanding and not in service of a prescriptivist point of view.
I'm trying, and there's always more room to get better with this, right? It was that Mary Jo Peebles book that really broke it open.
We're going to have her on. I'll have my people call her people.
Can I kind of just like lurk in the corner? Because I'd love to hear that.
Yeah, on your TAT, you did a whole story about lurking in the corner, but we're not going to talk about that in public. Thank you so much. Sincerely, this was awesome. We will absolutely do this again. There's so much to talk about. It was great.
And please continue doing this in the future.
Yeah, I appreciate that. Thank you. It's very kind.